Welcome. Thank you for joining me for Don't Be Basic, connecting laboratory testing to the field via evaluation of an advanced silicone foam dressing. I'm Dr. Laura Swoboda. I'm a translational scientist and a family nurse practitioner in Milwaukee, Wisconsin. Our objectives today are to discuss characteristics of wound dressings that matter at the bedside, to analyze lab data that supports absorption and adhesion qualities of Halyard bordered silicone foam, and to illustrate the cost effectiveness in the clinical setting. So we're going to be talking about the basic science, the bench science, and connecting that to what we see in the field and how we can merge those two. We'll start out by going over what don't we know. We don't know a standardized test for a dressing's fluid lock ability. I think of this as dressing reflux. So once the drainage leaves the wound bed, if the dressing doesn't lock that away, it can reflux back into the wound bed. So we don't have a test to say this is the level of a fluid lock ability. Same with odor control. We're not able to have an objective measurement. It's not standardized. The protection of peri-wound skin. We have some tools. We have some primarily used in research, ways to assess that, but really it isn't standardized. And also drainage-related pain. So when that contacts and causes dermatitis, those types of things. When I'm evaluating a dressing, I'm considering it in the context of the healthcare quadruple aim. And it used to be the triple aim. It's the quadruple aim now. And we're looking for improved patient outcomes, right? We want the best thing for the patient. We want the patient to have a good time, improved patient experience, and lower the cost of care, especially now. We're always considering the economics of it. That is the triple aim. Recently, it was expanded to the quadruple aim, which is an improved provider experience. So when you're using a dressing, you also need to be able to utilize that at the bedside, put it in place, and have an understanding that that dressing can do what you're expecting it to do. So that is a way to improve the provider experience as well. The ideal dressing from a wounds point of view would have no toxic components. So we talk about cytotoxicity. We don't want to do something that will damage human cells, our healing cells, but we also want to be removing the inflammatory exudate, the bacteria, all of the irritating components of wound exudate. A dressing also wouldn't cause that foreign body reaction that we see with gauze, woven gauze in the wound bed, and how that irritates surrounding tissues. The ideal dressing provides a bacterial barrier, so you're protecting that wound from outside trauma. It creates a moist wound healing environment. The adhesive will have the dressing remain in place, but not be so strong that when you're removing the dressing, you're causing skin tears or pain, excess pain. Minimal wound disturbance while you're taking the dressing off. So if we think about traditional gauze dressing and we're removing all that healing tissue along with the necrotic tissue. So unfortunately, a lot of the work that the wound had already done is being removed. So an ideal dressing would leave that tissue intact. And also to protect the tissue both internally and externally. So from a patient's point of view, the ideal wound dressing is painless, or it makes the pain better, right? It doesn't hurt at removal. The dressing materials would make the wound heal faster. It can stay in place and you don't have to deal with it. You don't need those repeated dressing changes. You can kind of set it and forget it. It may reduce your hospitalization time, hold exudate so that people can go through their activities of daily living. And these are what people tend to prioritize. And it's interesting, it does tend to differ from what providers tend to prioritize and what health systems, what industry tends to prioritize or think that patients may prioritize. So it's always good to have an understanding of what a patient's ideal dressing would do as well. and to be able to actually have objective tests to measure these kind of clinically meaningful results. And therefore, we can test various dressings with that same objective measurement and be able to say this dressing may be better at such and such, and have a more equitable conversation about what's occurring. Therefore, a series of lab studies were done by a third party, so outside of industry, to reduce bias, that evaluated the characteristics of some novel dressings compared to other common dressings. And what this lab study looked at was both the 4x4 dressings and then the larger sacral designs, because we know that the design of them changes the physical performance of them and how the tissues respond. So we had 10 different total evaluated. And what they were evaluating was the Halyard bordered silicone foam against other common clinical dressings that we see. So we can see a lot of other common dressings, and we don't have objective data that's shared open access from a third party that shows how these perform amongst various laboratory testing. We do know that how those dressings are constructed varies. They do have many similar components, but how they are constructed, even down to the microstructure, the size of the holes in the silicone, it really does impact the physical, the mechanical performance of these dressings. So it is important. A wound dressing is not a wound dressing. You say a foam, a foam, a foam. That is not true. We know from evidence that the microstructure can really change the clinical performance of these. One of the tests that we did was the point deflection testing, and that is how you can calculate a strain ratio. So in the lab, what we're trying to do is simulate a clinical scenario, but in a way that it can be repeated over and over and over again. So each dressing gets the same treatment, and that's science. That's how we find reputable, verifiable results, right? So with this test, we simulated the bony prominence of a bony prominence, primarily the sacrum or the heel. And it's put down into a foam pad at a specific amount of pressure. And we're measuring the amount of the dressing that is deflected. So the dressing's ability to spread that single point of pressure out. And you can see that kind of cone area, and it varies depending on the dressing that's tested. So when you're putting that point of pressure in, simulating the bony prominence, displacing that area, and then we can actually take measurements of the area that has been displaced. So here are the results from the point deflection and strain ratio. And we can see that strain ratio, again, that conical deflection, the diameter of the deflected material length, and how well the Halyard bordered silicone foam was able to disperse the pressure from that bony prominence throughout the dressing. And it's not only non-inferior, it's actually in the top performers amongst the other competitors. We also use the average force at finish to calculate the strain ratio. And the ratio, as we get closer to 1, that would be our goal, in that it's adequately managing those forces. And looking at the ability to do these across the dressings, what I'm seeing is there's not a lot of difference amongst them. And certainly the Halyard bordered silicone foam dressing is near the top in terms of performance. And certainly doing well to disperse those internal pressures. Another test that we did was the distance of nonconformity. So this one is something that happens in the field, and you can see from that photo on the top right there what that looks like in clinical practice. So that distance of nonconformity. Conformity in this point is the ability of the dressing to go into like the intergluteal cleft or to follow unusual skin contours. And when the dressing will not fully adhere to that skin crevice and will pop up a little bit, that is something that can be measured. So in the lab setting, it's placed on a mannequin, and the mannequin has all the parameters, even down to temperature and the moisture of the environment in the lab. Everything is considered so that every dressing goes through the same testing. And when you're looking at this, you want it to maintain a lower distance of nonconformity, right? You don't want space in between the dressing and the skin. So some dressings are not able to bend and to actually conform to the skin. When we look at this, we can see how the Halyard bordered silicone foam did. These are the sacral dressings for that testing and a comparison. So this is a 95% confidence interval. And the lower the values, the lower that distance of nonconformity, showing a good level of conformity, right? That it's either, you know, just a little bit or negligible. And if you're familiar with the other dressings, I think you can see, you know, and not be too surprised by ones that would have a very high distance of nonconformity, because it's a very stiff dressing that wouldn't conform. And this is going to really impact from a clinical perspective how that dressing is going to be used, because if it's lifting off, it's not going to be staying in place. It may need to be changed more frequently, and stool and urine can get underneath there and cause dermatitis and issues. So this is an important factor to consider in the field, and something that objective measurement in the lab can help inform your clinical practice. Another test that they did was friction and shear. So we looked at another simulated bony prominence, in this case a steel sled with a simulated bony projection, and they drag it across in a reproducible manner to show a human body weight, the friction and shear of that body against usually a hospital bed or other type of support surface. The maximum shear stress is really important because of the ability of a dressing to disperse that shear is critical, especially in pressure injury prevention. So when we're looking at the prophylactic use of these dressings, but also in wound healing, because we want to support the peri-wound to optimize perfusion and lymphatic flow and all of that. So when we're evaluating the shear stress of a dressing, we really want to see, is that dressing able to support those tissues in the best manner? The Halyard bordered silicone foam performed very well in terms of its ability to dissipate that shear stress. And again, you can see there's not a lot of variation even amongst all of the fields. So the question is, to what degree do these laboratory testings lead to differences in clinical findings? Another issue that we could consider is friction. So friction tends to disturb the more proximal tissues, right? And then lead to dermatitis, skin breakdown, and an altered skin integrity. When we look at the results here, same thing, performed very well. And we're looking at the coefficient of friction as well. When I describe the coefficient of friction, I'm thinking of when you try and get up from a leather seat when it's really humid and you stick to the seat, the humidity, the heat has changed the coefficient of friction on your skin. It's made it so you have a much higher amount of friction sticking you to that chair. And if you move very quickly, you're going to potentially cause some tissue damage, moving and tearing. So this is a way to look at that friction of the dressing against the skin and the friction of the dressing against the support surface, because those are two different things. But both of them impact their pressure injury risk. So again, here we can see the performance of the dressings and how Halyard bordered silicone foam performed very well in its ability to disrupt the friction. When we talk about the differences between the backing and the absorbent sides, it's because a dressing's backing will be able to slide against the bed, and impact the ability of the support surface to promote or prevent shear. So we also consider it from the backing and the absorbent sides. And here we can see what you would expect, which is a much higher amount of shear on the sticky side of the dressings. So that's what you're looking at with the higher bars. And on the lower bars, you're looking at that backing that faces the patient and the variation between them. And what I'm seeing is not a lot of variation between them, and that the Halyard bordered silicone foam performed very well amongst them. We also looked at pressure mapping. So pressure mapping is an emerging field in that it's emerging how we're quantifying it. Here we can see the pressure mapping results that were submitted by that third-party lab. And the Halyard bordered silicone foam's dressing ability to disperse what you can see on the left on the bottom corner, that coccygeal bony prominence. And we use these in the heel. And we know in clinical practice, we use them to protect a number of bony prominences. But in this case, we have a coccygeal sacral bony prominence adhered to a mechanical device in the lab that can be put down at the exact amount of pressure each time to show with this amount of pressure how each dressing will perform in terms of spreading that pressure out. When you're looking at pressure mapping, you want to see it spread out. You don't want to see that bright red because that's the tip. That's the highest amount of pressure over the bony prominence. And we know the higher the pressure, the less the perfusion, the more damage over time, right? So that pressure mapping in the bottom right-hand corner, that's the Halyard bordered silicone foam, and I don't see any red in there. So it has spread out the pressure from the tip of the bony prominence over the bony prominence and onto the surrounding skin so that those other tissues can help support the bony prominence. We also looked at fluid handling capacity. So this is what it looks like in the field, right? Right, everybody? This is what we have to deal with and what patients have to deal with, because when they're dressing leaks and they're out and about or they're at home and there's no one to help them, it's a big deal and it's a problem. So a dressing's fluid handling capacity is very important. And we look at its absorption and we also look at its moisture vapor loss because we want to promote undisturbed wound healing. So we'd like to leave a dressing in place if we can, allow it to absorb the drainage away from the wound bed, hold that exudate, that inflammatory exudate away from the wound bed, but also with moisture vapor transmission, diaphoretic patients, sweating patients, if it's hot or humid, they're ill, and the wound exudate itself, if you're using it not for prophylaxis, but for wound treatment, can go through the dressing and you can continue to leave that dressing in place and it can ultimately handle more exudate. The results for studying the moisture vapor transmission rate amongst these dressings, as you can see here, the average moisture vapor transmission rate when dressings are in contact with liquid, so I think about that as wound exudates primarily, and how high performing that Halyard bordered dressing is. So we can see it, certainly in the top two performing for moisture vapor transmission rate. And when we're looking at it in contact with water vapor as well. Now in the lab, it's important to look at both because in the clinical usage scenarios, we're looking at water vapor more representing a sweat situation, diaphoresis. So we're using these with prophylactic dressings, and its ability to keep that skin surface healthy is very important. And here we can see its ability to manage water vapor as well. The fluid handling capacity is then used to, is calculated by obtaining these, right? Because you're gonna measure both the amount that it's able to absorb and the amount that it can evaporate out through the moisture vapor transmission. And how well Halyard bordered silicone foam was able to do both of those. So in conclusion, the Halyard silicone bordered foam not only was able to show that it was not inferior to these other dressings, but that it was actually a high performer, and in some cases the highest performer in these objective, verifiable, repeatable experiments. This was done by a third party, so this reduces bias. It helps us to demonstrate that the Halyard silicone bordered foam dressings have high levels of success across these evaluative criteria. So we as clinicians feel comfortable in our decision knowing that this dressing will perform not only non-inferior to the others, but in many cases, superiorly. Thank you very much for joining me for Don't Be Basic, connecting bench science to clinical findings. I'm Dr. Laura Swoboda. Thank you.